You're listening to The Scoop on Ultrasound, where the world of ultrasound imaging comes alive through dynamic conversations. This episode is brought to you by EDM Medical Solutions. Be sure to follow the podcast on your favorite app so that you never miss an episode. Today, we explore how ultrasound is pushing regenerative medicine forward with expert sonographer and educator Leslie Aja. With nearly 2 decades of experience across OB-GYN, vascular, pediatric, abdominal, and MSK imaging, Leslie brings both breadth and depth to her work. With a strong focus on musculoskeletal ultrasound and ultrasound-guided injection techniques for regenerative therapies like PRP. She leads hands-on education and training for clinicians and industry professionals through MSite and Gulf Coast Biologics, while also contributing to national conference programs. This episode highlights the evolving role of ultrasound in regenerative care and how Leslie is shaping the skills, standards, and global reach of this rapidly developing field.
Quality supplies make a difference. At EDM Medical Solutions, we support over 2,000 healthcare facilities across the U.S. with high-quality medical products built for real clinical needs. From ultrasound imaging accessories to surgical instruments and everyday disposables, our portfolio spans women's health, men's health, and the operating room. We've spent over 35 years helping practices deliver safe, efficient, and cost-effective patient care, with the personal support only a family-owned company can provide. Explore our full range of solutions today at us.edm-imaging.com.
Welcome to The Scoop on Ultrasound. Today we're exploring how musculoskeletal ultrasound is advancing the field of regenerative medicine. Our guest, Leslie Aja, is a highly accomplished diagnostic sonographer with nearly 2 decades of experience across clinical specialties, from OB-GYN and vascular to pediatric, abdominal, and MSK imaging. She specializes in ultrasound-guided injection techniques for regenerative therapies like PRP, helping clinicians apply imaging with precision in therapeutic care. Leslie leads comprehensive education and training programs for both clinicians and industry professionals through MSite and Gulf Coast Biologics, where she also supports national conference programming. Beyond her teaching, she contributes to the ARDMS as a clinical specialist at Intelios, and serves as a RAD-AID international educator and program manager in Liberia, expanding global access to diagnostic imaging. Leslie, it's a pleasure to have you on the show.
Thank you so much. I'm really excited to be here.
Let's begin with your path into musculoskeletal ultrasound and regenerative medicine. How did you first get involved in MSK ultrasound and regenerative therapies, and what initially drew you into this field?
That's a great question. I actually started out with, I would say, 14 years of experience in other modalities of ultrasound. So, as you mentioned, I have certifications and vast experience in different types of ultrasound and MSK. I was working in a large healthcare system that had several musculoskeletal radiologists, but we only had one MSK sonographer. So there was a need for training. Rheumatology was growing in our area, orthopedics. We really needed new sonographers, and I asked to kind of be trained by one of the MSK radiologists. And it was definitely a learning curve, I will say. If you have a background in sort of everything else, when you transition into musculoskeletal sonography, you're learning pretty much everything that you kind of didn't really pay attention to before. So it was definitely a challenge, but I had a great team of basically 3 radiologists that I worked with and an awesome MSK sonographer that had a lot of experience. And they really pushed me and drilled into me the anatomy, physiology, functional movements. I feel really blessed that I had the opportunity to train under them. They were pretty strict. I had to train under them for 2 years before they would even allow me to sit for a musculoskeletal ultrasound exam, because they wanted to be sure that, like, not only was I academically proficient, like, I had other certifications. Yes, I could take the exam, but could I be a, superior diagnostic ultrasound tech? So I thought that was really great, and I feel really fortunate because a lot of people don't have that opportunity. I sort of fell into the regenerative medicine space, if I'm being honest. A position opened up for an MSK educator in my area, and I met with the CEO of the company, and he was extremely passionate about regenerative medicine, about MSK ultrasound, about expanding the field, and that he wanted all of the people using his devices and products to be able to do them in the best way possible. And he feels really strongly that that is through ultrasound guided injection and harvesting and things like that. So that's kind of how I got into the regenerative medicine space.
So interesting. The MSK ultrasound really is a fascinating subspecialty, right? And you don't hear about it too much, right? It's a kind of tight knit community. You hear more often of the other specialties, of course, because there are more sonographers there. But that being said, it's just so interesting, right, as a field. So very, very cool to hear how you got there. Sometimes it seems as if it's by chance, right? Just these encounters with different roles. Sonographers just have so many opportunities, really.
Definitely.
Now, when it comes to those regenerative techniques like PRP, precision is everything, right? And ultrasound imaging plays a key role in targeting the injections effectively. I think the audience would benefit a lot from hearing about your experience, in your experience in the field. What makes ultrasound such a valuable tool in regenerative medicine, both in terms of outcomes and the workflow itself?
These are all great questions. So, as far as ultrasounds for regenerative medicine, I think a lot of people think initially of like joint injection guidance, and that is a huge part of it. We know that you have real time imaging. You can avoid complex structures. You can avoid neurovascular structures if when using ultrasound. In regenerative medicine, there used to be kind of a school of thought that if you injected in the area that the themselves were going to kind of like migrate and cover everything. And we found over time that that's not actually accurate. So, a need for precise targeted injections is tantamount to like how your patient is going to improve based on what they received. There's been a ton of published papers on actually landmark injections versus ultrasound-guided injections in the musculoskeletal field, and it's really interesting to see that even very highly trained, highly skilled physicians that will perform specific injections. I know there's been studies on biceps tendon, on the knee. When you look at the actual numbers, with landmark, a lot of times they're about 75 to 77% accurate. And with ultrasound guidance, that number jumps to 95%. So if I'm a patient and I'm paying to have a procedure, I definitely would choose ultrasound guidance. Higher specificity, sensitivity. It's much better than a blind injection. The other side of it is the diagnostic scanning. MRIs can be challenging to get. There are a lot of times long wait times. So if you're a provider and you can actually perform a diagnostic ultrasound on your patient in the office without having to wait and them to come back, there's a time component that saves your patient time and money. And also, a lot of times the providers will actually treat them the same day. So I think that's another facet of it.
Yeah.
Being able to provide comprehensive treatment to your patient is really important in the regenerative medicine space. Kind of like what I was talking about earlier, where if you're just treating a joint and not treating surrounding structures, your patient could not get the symptom relief or that angiogenesis, that new tissue rejuvenation that you're looking for, that they will get if you provide comprehensive treatment. Um, an example of that would be if your patient had grade 3 osteoarthritis for a significant amount of time, and the supporting structures for that joint are going to have taken some wear and tear from sort of compensation from how the patient's been, like, say, if it's their knee walking, from having that kind of chronic osteoarthritic situation. So with ultrasounds, you can look at the joint, you can look at the cartilage, like, yes, confirm this patient has, pretty significant osteoarthritis, but you can also look at the meniscus. What's happening with the meniscus? Is it degraded? Is it extruded? Is there a tear? Medial collateral ligament, what does it look like? Do they have tendinopathy, tendinosis? And if so, you can treat all the supporting structures and your patient's going to have a much better outcome.
Incredible, just the accuracy, right? How it enhances the accuracy, like you were saying in the beginning, that number jumps to 95% wasn't like high 90s. Really incredible just to see the way that having that clear view, right, provided by ultrasound changes everything. I mean, it makes sense. Now, do you think that we still have ways to go with the adoption of ultrasound, or do you feel like the field, that's it? It's we're moving that way, or have you still encountered maybe some resistance from physicians who say, well, I could just do it freehand?
I definitely think there is resistance. It's sort of an older school of thought on people somewhat maybe like set in their way, and their patients have had good outcomes. So they might not see the clinical need for it. The data coming out now, we didn't have a lot of data before with regenerative medicine. If you look at 20 years ago, people would say, like, oh, PRP, that never works. Now we see that no, it does work. But there's a lot of nuances with it. So, are you targeting your injection with ultrasounds or like imaging guided fluoroscopy? A lot of people use fluoro for spine still. Um, is your platelet dosage what it should be? So, by that, I mean, are you using an actual device that captures a certain percentage of your platelets back? There's a lot of published information. You need 10 billion platelets for this diagnosis or 3 to 5 billion platelets for this diagnosis. So, if you're using some devices that don't have that recovery rate, again, your patient's not going to do well. So, you really have to kind of like dive in to the research. It's not just ultrasound, it's like comprehensive research on everything. But I think that the field is moving that way. It is expanding that way. There's tons of musculoskeletal ultrasound conferences. Almost any regenerative medicine conference that you go to has an ultrasound component for sure. And a lot of our providers and like key leaders in the field are masters at ultrasound themselves. There's like one that always says your injection is only as good as your image. And that I appreciate that because I think ultrasound has a significant misconception from the general public that you're just kind of like taking pictures, right? Uh, if I know what I see and I like place the probe down, then I know what I'm looking at. They don't really see the diagnostic challenging learning curve that comes with it. It's 2 to 4 year program that someone's going to learn how to do it. So I think that's like one of the biggest challenges is getting providers to kind of lock into that notion that they're going to have to do a lot of repetitive scanning, that there is a learning curve, that there are a lot of artifacts like anisotropy and musculoskeletal imaging that can really throw you off. So I think that the biggest challenge is just like bridging that gap between the new provider just learning and getting really advanced in diagnostics and the misconception that it's easy.
Right. Right, because ultrasound imaging itself, at least from my understanding, right, is not really standard for these physicians that are coming out of medical school, right? Especially with all the nuances that you said. So it does require training. Do you think that besides what you mentioned of the old school of thought, do you think that there's a certain extent where it's like, it's too much time and effort to go through all this to learn it? Do you think that that also contributes perhaps to some of the hesitation that you see in the field?
I think there's like definitely because there's such a desire to push the field forward, I think that there is more of a desire for people to learn. It is an ever-changing field. I mean, every day there's a new study coming out. Every day someone's publishing something different. It's like staying abreast of new research all the time. And I think that because of that, it's amazing. There's definitely a huge push that people need to learn ultrasounds. I think a lot of physicians that may be hesitant to it, they're really busy. They have established practices. It's time consuming. It's time consuming for your patient when you haven't been doing it. It's time consuming for your staff. It's time consuming for yourself to like take the time to learn it outside of your practice hours. So that's something like I feel like we really try to help. We have physicians where I'll just go in their office and work with them for a couple days. Like we'll pick a couple joints. Like by joints, I mean joints and all the surrounding structures, and just like focus on those for a couple days. Just it's that repetitive motion is so repetitive repetition is the mother of learning. So definitely true with ultrasound.
That makes sense. That makes sense. And do you think that the shortage that we have of sonographers in general, right? I'm including all subspecialties, but then especially including MSK, just that there simply isn't enough. Do you think that that contributes perhaps to the speed of the adoption, besides physician education, which of course takes time and effort? Do you think that there not being sufficient MSK sonographers only exacerbates how the speed by which we can adopt ultrasound imaging in the field?
Yeah, so this is a really good point, and it's a serious one. There is a definite deficit of musculoskeletal sonographers in the U.S. and Canada. I can speak to, and I would assume globally. There are, thousands of other types of sonographers, and just in the subset of MSK, I think there's like 600 and something. I have to look at the number registered between Canada and the United States. So the problem lies with there are a number of prerequisites. You need to complete 150 scans. You need to be signed off by an MSK certified sonographer or an MSK radiologist. And if you're in an area that doesn't have that, it's really challenging. Like, how are you going to get the training? Our sonography education programs, like, very slightly touch on MSK, but they don't do a deep dive on it because their sonographers can't sit for the musculoskeletal exam until they're already certified. So they will have already done like physics, they will already done a subspecialty. So there just isn't as much of a learning opportunity there. So I think that's something like as a sonography society, we need to work on expanding.
Do you think that as of now, the different societies that we have, the ultrasound societies, which there are several, do you think that we are still not making sufficient progress to prioritizing MSK? Do you feel that there's still work to be done in terms of the awareness around it? And in addition to that, with all the ultrasound programs that we do have in the US, from what you see, do you feel like MSK still is not yet being prioritized to the point that it needs to be for us to really see that sort of shift that you're referring to?
Yeah, I think in traditional medicine, the standard was to always go to MRI for anything musculoskeletal. And MRI does have its place. And for certain pathologies, MRI is the gold standard. But in other conditions, ultrasound is the gold standard. So we need to make it more readily available. With ultrasound, you have dynamic real-time imaging. MRI is static. So you might have a patient, I've had several of them that had an MRI that looked normal, and then you actually dynamically stress the joint and open up, and wow, that tendon tear opens up. I had one myself. I had a subscap tear. And on MRI, it said I had a 3 millimeter tear and some other stuff going on. And then when I had a physician actually perform my ultrasound and I externally rotated, my tear was 1.4 centimeters. This huge difference. It technically could be surgical, right? I did treat it with orthobiologics and it's better, a full range of motion. So I'm happy about that. Um, but there is a place for ultrasound, and I think that traditional medicine needs to like shift in that way.
Right, right. Yeah, that makes sense. Really, really interesting just to see how we can address, right, the need for MSK ultrasound, both sonographers and then physicians using it with the speed at which regenerative medicine is going, right? It feels like the train already left and we're trying to catch up for sure.
Exactly. And globally it is moving. And they're doing a lot of different things that we haven't been doing. I mean, the ESSR was way ahead on musculoskeletal ultrasound than ACR. So I think eventually we'll get there, but there's definitely like a learning bridge.
Exciting. Now that we're on the topic of education, right, and the moves we have to make to improve the state of things, let's talk a little bit about the exams because you also help support the creation of the standards that guide sonographers and physicians alike because you work as an item writer and reviewer for the ARDMS, or you support the ARDMS in this way, right, with your role at Intellios. So could you tell us a little bit about what considerations go into crafting effective and clinically relevant certification exams, especially in a field as dynamic as MSK ultrasound?
If you are high-level disinfecting your ultrasound transducer, it's likely you're soaking the probe or using an automated HLD device. But there's a better option out there. TriStel Olds can high-level disinfect your transducer in just 2 minutes and costs under $3 per cycle. Sound too good to be true? Request a brochure today and learn why so many practices are switching over to TriStel Olds. Visit us.edm-imaging.com/TriStel. That's TRISTEL. And now, back to the show.
Yeah, so I am the content specialist for the APCA RMSK exam and also the ARDMS MSKS exam and pediatric sonography exam. I used to be an item writer. Our item writers are volunteer, and then I converted to a position with Intelios. So my role now is working with the assessment committees on exam creation and on content. Is the content relevant? Does it still meet current practice? Are the items coming in according to our content outline? I think it basically starts with like your content outline for your exam. And there's tasks on each content outline. And interestingly, we are like in the process right now of sort of working a lot on the RMSK one. You know, practice changes, technology changes, the people taking the exams change especially on the provider and physician side. And that exam has sort of exploded globally. So there's a lot of work that we're doing right now on revamping the content outline and doing a practice analysis. So in the last week, if you're an RMSK certified provider, you should have received an email, and we would love for you to fill it out this month. I don't know when this airs, but it essentially looks at what field are you in? How many MSK exams are you performing? Who is your patient population? Do you do pediatrics? Do you not do pediatrics? What kind of pathology are you treating? Are you rheumatology? Are you regenerative medicine? Are you orthopedic? Are you radiologists? Originally, the bulk of people taking the RMSK exam were radiologists, and that's not really the case anymore. So the content needs to reflect that. A funny thing that came up in one of our committees was a provider was like, what is knobology? And you know, as we've shifted into handheld and point of care devices that a lot of people are using, they don't have knobs. Like, I'm a sonographer and I love knobs, but a lot of our newer physicians don't. So the question is, you know, is it relevant? Is it not relevant? Who's it relevant for? How many people is it relevant for? Can we use this term? A lot of the physics is now built into our ultrasound machines, which is amazing. But our physics items from, 2015 or 2014, are they still relevant or not? There's just a lot of questions. We have emerging technologies, elastography, contrast ultrasounds. Like, how is that going to play in with the field of musculoskeletal ultrasound? There's still a lot to figure out with that. So, and there's a lot of studies being done and a lot of studies being done on athletes and return to play with elastography. How valid is it? We're waiting for a lot of data still. With test creation, a lot goes into it. We have an assessment committee. I'll talk about APCA RMSK specifically, since that has to do with Regen Med. There is an assessment committee that's appointed by APCA, and they sort of oversee these content outline creation. Then there's a volunteer committee that actually gives feedback and information on the data. There is a process by which everyone meets, and item by item will go through questions to see if they are relevant or not. Psychometrics will weigh in on items currently in our bank. They weigh them for difficulty. Sometimes we get rid of items because they don't test well. Sometimes we may have an item that came through that looked good, but when it got tested, 70% of people missed it and they all marked B, but B wasn't the key. So why did this happen? And then if that does happen, just so people know, you're not being penalized on your exam for that. So they're always constantly looking at data. We always want to create a fair standard exam that everyone can understand. First off, the item. Second off, why we're asking it. Is it relevant? Is the image good? We're always looking at ways to improve our exams.
That's great. That's great. Yeah, getting a sneak peek right into what goes into it is very interesting, I think, for everyone who's on the clinical side only and not really involved in that education aspect. Now, moving on to the work you've done training different clinicians. We know that, of course, you train physicians, and others, right, in the use of ultrasound, specifically MSK ultrasound. So, what would you say are some of the most important elements to focus on when you're training in ultrasound guided injections or MSK protocols for someone who is not an MSK scenario?
I think that a big portion of it is before you even pick up the probe, doing a deep dive on kind of anatomy and physiology is really important. If your background is not orthopedic heavy, it's really challenging to learn all the ligaments and tendons and bones. And a lot of our docs are amazing. They did it in medical school. They still use some functional pieces of it, but actually refreshing on all of that, I think, is really important. So that is kind of something that for the next year, Gulf Coast Biologics that I work for, we're partnered with another organization and they provide a lot of online learning modules that we're going to have as like prerequisite before you even come so that then you can really get the most out of your ultrasound training once you're there. I think that's very important. I think starting with, if you're doing joint injection guidance, like in the shoulder, you have so many targets. So starting with basics, glenohumeral joint, biceps tendon, supraspinatus. 90% of your rotator cuff pathology is in supraspinatus. So starting with easily identifiable structures and gaining confidence in them and then building your protocol. And so after you've done the repetition on those, adding to it. And that's another reason why it's good to go to beginner courses, really get good at what's offered in the beginner course, then go to an intermediate course and then to an advanced course. A lot of people, come in with that misconception that I'm going to go to a weekend ultrasound course. And I saw it a lot when I worked in the hospital system too, with the ER, with point of care. I can remember getting called in the middle of the night because the physician found something and I get there and be like, well, I don't know what you're looking at because that's not that. But they had been to a weekend course and it's not their fault. Really just honing in on this is continual learning and everybody's got to start somewhere and you've got to crawl before you can run. That's what I think is really important.
Now, the determination to want to learn the modality is very important, isn't it? Because it's not going to be, like you said, it's not just the weekend course. It's not as simple, but it's so, so powerful of a tool, right?
I mean, I've been doing ultrasound 20 years and I learn something all the time. So I think that is like my, primary career. I don't have all the other things that these physicians and providers have, and I'm still continually learning. So I think having that humility is really important.
Speaks volumes to the complexity too of the modality and how it's always evolving, right? Always advancing forward. Now, moving on to global health, because you have been involved in global health initiatives. Your work in Liberia with RAD-AID really is a powerful example, right, of how ultrasound can expand access to care in underserved, under-resourced areas. So, how has your work with them shaped your perspective on sustainable imaging education? And how do you approach training in environments with such limited resources at times?
Yeah, so I grew up volunteering. I grew up volunteering in all different types of things. But when I first started volunteering in sonography, I volunteered locally. I did OB scans for women in prison, did firefighter screenings for free. I did some volunteering in Central America where I went and saw, 50 patients a day. I've also done that domestically. The only thing I really felt like when I got home, I had this from Central America specifically, I had this like nagging feeling that I just wasn't satisfied. No one was going to be going back. There was no deployment after me. Who was going to take care of these patients? These patients got all these diagnoses. How are they going to follow up on it? And I was actually at a volunteer project for migrant workers. And someone told me about RAD-AID in 2017. And I looked them up online and there was a conference in DC. And I was like, I'm going to go. I didn't know anyone. I showed up at this conference. I met a ton of amazing people that were incredibly passionate about global health. We hear the statistic a lot. 2/3 of the world lacks access to basic health care. That means that 2/3 of the world lacks access to radiology. Translation, 2/3 of the world lacks access to diagnosis. And we really see that reflected in the life expectancies, in the healthy life expectancies, in the maternal fetal death rate. These are all things that I am incredibly passionate about. And RAD-AID's main purpose is to bridge that gap and provide educational resources in low and middle income communities by all different ways: equipment donations, PAX donations, sending teams on the ground for training people. Liberia specifically is very special to me. I've been doing work there for a while. Just for statistics, there's 5 million people in Liberia. We currently have 5 radiologists, it was 4, that serve those 5 million people, and there is no sonography program. So those 5 radiologists, who are all from Ethiopia and Nigeria, perform all of the ultrasounds, minus some OB that they've been working on training OB nurses. The numbers are like staggering if you think about it. If you live in a populated area like I do, where the healthcare system I worked with had almost 100 radiologists, right? It's like, it's insane. So they do the procedures, they do the scanning, they read anything, any other equipment that they have: CT, X-ray. Liberia's mammogram hasn't worked in a number of years, and we're working on that right now. MRI, they have 1 MRI in the country. So they're responsible for everything. They work 11 months a year. They get 1 month off, and they work 7 days a week. So RAD-AID really saw a need in Liberia to provide support. We've had a lot of equipment donated, which we're really grateful for. And we've deployed teams there annually for several years. I myself was there this year and last year. And my primary goal there was working with MSK radiology on the radiologists and nerve mapping, for instance, with anesthesiologists. And then also for OB ultrasound, do a lot of work with the OB sonographers there. So they still have a ways to go on their maternal fetal death rate. So it's been amazing. I love the people, the community, the culture. I love when I get a message that someone found something that, like, not even necessarily me, but someone that went over there showed them, and they're like, "Oh, I found this. Like, how cool is this?" So it's definitely been extremely rewarding. And there's been a cultural shift. People are afraid to go to hospitals in some of these places. You get substandard care there. When the maternal fetal death rate is higher, pregnant women are even afraid to go. So RAD-AID also works for like medical education for the communities. So people know, like, hey, you need to go get this checked. You need to go get this screening. Like, don't wait till 39 weeks to go get your OB ultrasound. It's a really broad problem.
Yeah, I mean, hearing about 5 radiologists serving 5 million people. So each radiologist has a pool of 1 million patients is just something that's really staggering. It's a staggering number. It's incredible. It really shows the sort of inequity that there is, right? Globally, in some countries, unfortunately, the lack of specialized care available. And I'm sure there's other issues with a system like that you could say, other like a lack of other sorts of specialties as well. But just looking at imaging alone, to have only 5 radiologists is really a critical issue for a country with so many people. So just great to hear the work that you and RAD-AID, of course, are doing to alleviate that problem. I'm sure it's so helpful.
I will say Liberia launched their first ever radiology residency program last year. So we currently have 5 residents. They're working with the radiologists in country and the West African College of Surgeons, and we're just really, really excited. RAD-AID supports them through local chapters. We have a lot of hospital chapters in the U.S. Johns Hopkins supports Liberia a lot, so thank you to Johns Hopkins for that. Through webinars and Q&A sessions, and RAD-AID has a whole lot of online learning platforms. So it really is a comprehensive educational program.
That's great. And I mean, that really is the solution, right? Where you're saying that now you have the next generation
Exactly.
of radiologists being trained there in their own country. That's what's sustainable, right? As much aid as we love to send, then the country themselves, their own healthcare system is unable to develop. It's always like having a crutch. So just to see organizations like RAD-AID then build up, right, the next generation and educate them there is fantastic, to really, really see that. And that's really what moves the needle, right, in global health, is developing systems within the country itself, not just always sending help, but also educating. So really great to see how imaging access is expanding through that sort of education effort. Really, really impactful, not just at home, right?
Yeah.
But in other countries too, where you can see the power of a portable imaging modality like ultrasound It really highlights its power, right? The fact that it's less expensive, perhaps easier to train, easier to move at least. It really makes a difference. It does. It does. Now, let's move on to really what is the clinician's role, right, in advancing regenerative care. I think we should speak directly to the clinicians listening. What advice would you give to clinicians considering MSK ultrasound for the first time? And so for those who are in regenerative medicine and they're considering adopting it, what's the advice that you would give? And what do you believe is their most important role in advancing the safe and effective use of regenerative therapies?
That's a really good question. And a lot of people getting into regenerative medicine, they do start with like joint injections. We see it constantly. So most people that come to us for training are already actively doing some form of regenerative medicine. Some of them are just starting to get into it, but a lot of them have already kind of stepped into it. So I think if you are a clinician considering regenerative medicine, start right, start with ultrasounds. Now, landmarks are great. I think landmarks are great when you're learning in the sense of you can palpate and then place your probe and then like really see what you're looking at. Sometimes when I have a physician or clinician that will say like, "Oh, but I'm so good at it." And I'll be like, "Great, show me. Like put your hands on it. Let me see." And a lot of times they're not exactly on the structure, right? They might be close to it, but they're not on it. And I think that in itself is like the most powerful way to teach someone is to kind of like, okay, show me and I'll show you. And like they come to their own conclusion, right? But if I think if you're getting into regenerative medicine, do a lot of research. There are a lot of companies, there's a lot of information, there's a lot of misinformation. So go with a company that supports you. Go with a manufacturing company that is going to give you superior outcomes because they have a superior device. Do the research on published studies of how many platelets do you need, like what is the best method for this, and then which injections work the best. There's a lot of adjunct therapies, honestly, with regenerative medicine that work well too. There are organizations like Data Biologics. They do tracking, they track outcomes, so they're patient reported, and they do all sorts of different therapies, but most of them are using ultrasound guidance, and you can actually see it reflected in their patient outcomes. So I think it's important to actually look at data before you just jump into something and then make the best choice for you for your patient care. That's how we're going to advance the field.
Yes, no, definitely. Just incredible, all the opportunities that are present with ultrasound. It's an exciting bandwagon to jump on, right? It's a really big movement. So I think that just off of everything that you said, I think is enough encouragement, right, for clinicians to take that vital step and look to really integrate ultrasound into their practice. Leslie, thank you for taking the time today to share all of your insights and to share too the work that you've done globally. It really is encouraging, right, to see how our clinicians here at home support others who are abroad in more underserved areas to advance care, not just domestically, but internationally. That really does make a difference. So thank you.
Thank you. I'm going to give a plug. If anyone wants to go to Liberia, Leslie Aja at RAD-AID.org, let me know. We have funds. If you're a stenographer, if you're a technologist, if you're a physician, radiologist, family medicine, if you want to go to Liberia or any other country, check out RAD-AID. We would love to send you.
Thank you for listening to this episode of The Scoop on Ultrasound. Subscribe today to be notified when new episodes are released, and visit our website, us.edm-imaging.com, to learn more about who we are and what we do.